Our next case, we're going to be looking at cervical radiculopathy case. Physical therapy diagnosis was C7 radiculopathy with the right upper extremity muscle power and strength deficits. Patient's primary complaint was neck pain and right upper extremity pain and weakness. So our patient presented to the clinic with general neck pain that began on January 11th, working out at the gym. Pain began to worsen and peripheralize to the right upper extremity with some weakness noted. Over the next 2 months, various physicians were consulted before trialing PT. Patient presented with constant pain, numbness and tingling beginning at the right shoulder and traveling down to the elbow with constant pain in the neck. Pain increased by standing, running, walking, driving, and decreased by laying on his side with his head fully flexed and supported. Patient works from home at a computer, but also has to do a lot of flying and driving. He denies any significant change in the weight over the last 6 months, signs and symptoms of Cotter-Quina syndrome, night pain, nausea, and vomiting. Some usual screening questions there. MRI revealed C6-7 lateral disc protrusion. Patient had a little relief with injection in the neck, and baseline NDI is 38%. So our objective exam found a forward head posture, bilateral scapula downwardly rotated and protracted, right side greater than the left, so symptomatic side. Active range of motion revealed dysfunctional, non-painful flexion, and extension and rotation in the cervical spine. And then side bend with retraction was normal to the left and dysfunctional to the right, so difficulty loading that right side. Thoracic spine, seated rotation with the arms overhead, revealed 80% motion to the left and 60% to the right. Shoulder range of motion was normal, bilateral, and throughout. Our strength testing looked pretty good overall. However, what we found was in the elbow, extension was weak on the right side, as was wrist extension. And then when we moved on to the rhomboids, there was some greater weakness, believe it or not, on the right side. And then particularly what stood out to me was also the serratus anterior. So scapular retraction and upper rotation was definitely dysfunctional on both sides, but more so on the right. VBI testing was negative using the 5Ds and 3Ns. When we got to joint mobility assessment, C4 through 7, side glides to the left were dysfunctional. And we have to remember that that is a relative right side bend when we're gliding to the left. Normal OA side bend mobility, hypomobile cervical rotation with the flexion rotation, side bend rotation test. With flexion rotation, we were dysfunctional loading to the left. And then hypomobile PA of C7 through T5. The neuromuscular screen was negative for dermatomes, however, reflexes revealed decreased reflex at C7 on the right side. Special testing was negative for any ligamentous instability. However, we had a positive distraction test, a positive median neural tension test, positive Sperling's test on the right, and deep neck flexor endurance test was a 9-second. Movement analysis showed decreased upper rotation with flexion and abduction on that right side, and they had a little apprehension at end range cervical extension and right rotation. So again, anything loading that right side in the cervical spine. Now, when we're trying to come up with a diagnosis, remember our cluster for cervical radiculopathy is positive Sperling's, positive traction or distraction test, positive median nerve tension test, and decreased cervical rotation to the valve side. I believe it's less than 60 degrees of rotation. If we have 3 or 4 of those, it's pretty highly likely that the patient presents with cervical radiculopathy, which leads into our treatment methods. So our first choice intervention is manual therapy plus exercise. The research has shown that a thoracic manipulation is not only safe, but it also can be essential and very effective in improving neural mobility and neural tension for patients with upper quarter issues. It can also apply to lower quarter as well. Thoracic manipulation for neck pain can improve outcomes and has been shown to be beneficial for cervical radiculopathy. And then the research shows that if you combine manual therapy with exercise, outcomes are even better than manual therapy alone or exercise alone for cervical radiculopathy. You want to make sure that you're doing some cervical stabilization and scapular strengthening to address your impairments, but also some of the scapular deficits, and then work on thoracic mobility to reinforce the impact of your thoracic manipulation. Our second choice intervention is mechanical cervical traction. Now, there's a cluster that age less than 54, dominant arm not affected, looking down doesn't worsen symptoms, and then treatment involving manual therapy, cervical traction, and deep neck flexor strengthening for at least 50% of the visits. If they're all four are involved, there's 90% success rate. If three are involved, 85% success rate. And then the less involved, the less the success rate. So absolutely, if your patient falls into this category, you better make sure you're doing some manual therapy, some cervical traction, and deep neck flexor strengthening. I'd also recommend including a thoracic manipulation to that and general strengthening as well. Mechanical traction has been shown to be more effective than manual traction. So if you don't have the big machine in the clinic, you can look at getting one of those smaller devices online. I often have patients purchase those for themselves just so that they can perform it regularly. So an example treatment session would be start off with some manual therapy with a thoracic manipulation, some mobilization to the AA joints due to the restricted mobility, some I-stim to the right upper extremity and scapular region to address some of the neural mobility deficits and also the threat to the nervous system. Follow that up with some strengthening, starting with some cervical spine stabilization training, work on the motor control deficits if you saw any abnormal patterns, so chin tuck with rotation, quad rock back with chin tuck to strengthen the posterior aspect of the spine while maintaining neutral. Wall shrugs with chin tuck, prone T's and Y's, wall push-up plus, all those emphasizing upper trap and serratus strengthening to encourage that upward rotation and elevation of the shoulder blades, and then some tricep kickbacks to work on strengthening the triceps. Finish that off with a little bit of mechanical traction. Recommend intermittent over sustained if possible, as I believe the impact is a little more effective with intermittent. So some of our take-home points here are manual therapy plus exercise is effective in improving outcomes for cervical radiculopathy. So don't think you just should have your patient do exercise, and don't think you should just do manual therapy, but combine the two. Make sure you're incorporating cervical traction at least 50% of the sessions, as it can improve outcomes for cervical radiculopathy. Now, it's essential to consider those other factors as well, such as also include cervical stabilization training and some manual therapy. And then if the patient's it's not the dominant arm involved, if they're less than the age of 54, we have to consider all factors for that statistic. And then don't let the imaging dictate the patient prognosis, as many have bulging and herniated discs. I believe something like 70 to 78% of patients in their 20s with no neck pain have bulging discs in their cervical spine. So you're probably going to have to start off with some education with the patient and say, hey, just because you have that herniated disc in your neck doesn't mean that you're stuck with the pain that you have. It is very possible that you can get back to a pain-free state and never have to worry about that image in the neck again. And then also a multimodal approach is recommended in every case, as no single treatment typically returns a patient to prior level of function. So whether you're including dry needling, traction, scapular strengthening, whatever, keep your treatment plan pretty holistic or multimodal in order to try and have the best impact for your patient. But for sure, incorporate the techniques and the treatment styles that the research has shown to be effective, such as traction, thoracic manipulation, manual therapy, spinal stabilization, things like that.